you came to be interested in this topic.
Thank you very much. First of all, I'm very glad and tremendously honored to be invited to speak in the Center Seminar Series to such a wonderful audience. So welcome everyone from my side as well. So I studied these topics such as chronicity, because I'm very much interested in how agency and knowledge co-constitute each other. Health institutions and health policy are among the sites that I find most interesting because expertise directly intervenes in our bodies and minds, and because health is essential to everyone. For the very same reasons, I turned to urban mental health and lately to climate change. It is important that we better understand how cities and the climate crisis redefine our knowledge and experience of health. How can agency be maintained? Not least because of the COVID-19 pandemic, we can all tell many stories about these issues, for sure. To draw a connection to my talk today, I think that it is through concept work that social scientists can best contribute to the remaking of our techno-social worlds. Today, I would like to invite you on a short journey to unpack the concept of chronicity. I would like to share my presentation now. Just a second. Okay. It looks like if it works, very good.
Perfect.
So chronicity, why this term? What is chronicity? How does it relate to the health system and the agenda of the center? As I've just said, today I want to invite you to rethink the concept of chronicity. My aim is to show that it does not just label an illness or an experience, but that it is fundamentally implied in arranging our care system. But let's start at the beginning. There are many understandings of chronicity. In general, chronicity is a term that helps to address the temporality of something. Chronicity qualifies something that occurs over time. The online Oxford Dictionary defines chronic with regard to an illness as, I quote, persisting for a long time or constantly recurring, often contrasted with acute, end of quote. A look at history of Western countries like the UK or Germany shows, roughly speaking, that the classification of an illness as chronic has played an important role both in establishing psychiatry as a medical specialty and in challenging psychiatric power, especially the confinement of people in large and enclosed mental asylums. The concept of chronicity thus has a crucial history with regard to psychiatry and mental health care. In our seminar today, I aim to present you an ethnographic perspective on today's linkages of chronicity with the mental health care sector. The basis of this approach is to turn chronicity into an empirical artifact. The question is, what does that mean and how do we do that? The answer comes in two steps. First, we start with daily life and get curious about what meanings the concept of chronicity acquires in everyday practices. That is, we refrain to presuppose a given definition of chronicity in the beginning of our study. Instead, we want to learn about chronicity through ethnographic research by asking where, how, and for what purposes the concept is used in practice and with what effects. Next, we shift our analytics from discourse to practice. We choose ethnography as our approach and involve ourselves in the routines of mental health institutions in order to learn about the daily activities of service users, patients, staff members, and other participants in mental health care. We do so because we want to know what difference the concept of chronicity makes in everyday care practices. The following empirical questions are at the center of this ethnographic approach. In what situations do people refer to chronicity in daily practice, and whom does this affect? How is the concept used for purposes of classification? My main argument is that it is these routine applications of the concept that define chronicity today. Please note that this practice-based ethnographic research approach is different from an interview study on these questions. With interviews, we could elaborate how people understand chronicity and what experience they have. With the ethnographic approach just presented, we instead start from practice and explore how people in health institutions resort to the concept of chronic illness and with what effects. This is very important because chronicity is a consequential concept precisely because it shapes institutional healthcare practices. Only when we know more precisely how the concept is embedded in daily care practices can we fully assess its importance for promoting or preventing particular changes in the mental health care system. In my remaining presentation, I will give 3 examples from my ethnographic research in the German health system. In this case, referring to research I have conducted in mental health facilities in Berlin from 2011 to 2013. You can find these examples and more about my research on chronicity in my article titled Chronicity in Action, which has been published in the journal Sociology of Health and Illness in 2018. Having said this, my research is embedded in the German health system, and I am aware that many cases and situations I have explored hardly apply to healthcare in the UK, if at all. However, I very much hope to pick your interest in my research approach and to learn more from you in the later discussion about the NHS and the situation in the UK. My first example is from a psychiatric day hospital. It's about shaping the treatment path. The day hospital was part of the psychiatric department of a public general hospital. The hospital is known for its social psychiatric orientation. In 2011, the day hospital offered approximately 30 places for voluntary treatment for people with a diverse range of psychiatric diagnoses. The facility operated all weekends included, during daytime only. Patients were required to be present throughout and return to their homes in the evenings. In the day hospital, doctors discussed once a week with the senior physician the course of illness of all patients. This doctor's conference is our first case. For the purpose of this weekly meeting, one of the doctors collected all the paper medical patient files. These files mainly entail information on the drugs prescribed, the actual intake of meds, as well as laboratory test results. The doctors then sat down together around the table in one of the doctor's rooms. During one of the sessions I attended, the senior physician classified the illness of one patient, whom I call Miss Komulu, as chronic. Here is my ethnographic note of this situation, and probably you have already started reading it. So I will read it out loud. The senior physician is looking into the patient record of Miss Komulu while the medical resident, who is in charge of her treatment, begins speaking. Miss Komulu has a schizoaffective disorder. She has a husband and a child aged 5. She came to us taking Tavor, lorazepam, an anti-anxiety drug, and we are switching her to lithium, a mood stabilizer now. The senior physician continues. Is she still having a thought disorder? The resident answers, no. I think we will keep Miss Komulu 3 more weeks. This week, we introduce lithium. Next week, we stop Tavor. And during the last week, she can take half days off. The senior physician looks into the patient record and states that regular blood checks are obligatory now. The resident nods and the senior physician continues. Ms. Komolo has been here for 5 weeks. If she is to stay 3 more weeks, we will do well to invite her husband. Ms. Komolo's illness is chronic, and it's important to figure out what role her illness plays in her family. This is the end of the ethnographic sequence. While the senior physician looked into the files of Ms. Komolo's patient record, the medical resident summarized Ms. Komolo's treatment situation. The plan for the upcoming 3 weeks was to switch Ms. Komolo's medication from Tavor to lithium. Reflecting on the length of Ms. Komolo's hospital stay so far, and with a view to the presumed future treatment duration, the senior physician suggested to include her husband in the treatment plan. The doctor argued that Ms. Komolo's illness was chronic, and it was important for therapy to know how the family dealt with her illness. From this ethnographic note, we cannot derive how the physicians thought about chronic illness in general, or in Ms. Komolo's case in particular. What I take from the note instead is that during the act of considering the length of a patient's hospital stay and her psychopharmacological treatment path, chronicity is mentioned as a qualifier of the patient's illness. And it is used to support the argument for including the patient's family in therapeutic activities. We can draw from this situation that the concept of chronicity participated in shaping the treatment path of Ms. Komolo. The major trajectory of this path was set out by the medication plan. Cross-tapering Ms. Komolo's medication was estimated to require 3 weeks. This period of time was given priority, and it set the framework for the desired involvement of her family. Classifying Ms. Komolo's illness as chronic added her family to the routine psychopharmacological treatment program. It extended the therapeutic focus beyond the temporalities of the hospital to the temporalities of the family. Chronicity therefore pointed to the limits of hospital care and to the fact that illnesses are managed in the family for the most part of life. This is my next situation, which is about qualifying the hospital's scope of responsibility. In this situation, the act of using chronicity as a classification qualified the day hospital's scope of responsibility. This time I was sitting next to a doctor, this time a medical resident, when he was documenting his recent interactions with patients in the hospital's digital information management system. And here is the note. Using the mouse, the resident navigates to Ms. Massad. While documenting his interaction with the patient today, he turns to me saying that Ms. Massad is a classic example of chronification. He explains that she will be discharged from the day hospital without the hope of finding an available Arabic-speaking psychotherapist in town. Openings with these psychotherapists are rare and they have long waiting lists. On top of everything, her residence permit is valid only for 3 years and depends on her current work contract. She is working far below her qualifications and she does not feel she is being treated well at work. The resident continues that the senior physician has argued for limiting her stay to a maximum of 4 weeks, so she will be released by the end of the following week. While entering the record of Ms. Massad, so end of the sequence, while entering the record of Ms. Massad, the medical resident explained to me that he considered her case a classic example of chronification. If chronicity is a difficult term, then chronification is even more so. The German language is full of possibilities to expand nouns in order to stretch their meaning. Chronifizierung, or the translated term chronification, is such an example. The term refers to a process of getting chronic. At the end point of chronification, an illness will have become chronic. The term extends the temporality of chronicity and enables reference to a time that precedes a chronic illness. Let's remember the situation. While the doctor was documenting his therapeutic interaction with Ms. Massad and her current health status on the computer, he explained to me how intricate her situation was. Ms. Massad couldn't leave her arduous job because her residence permit depended on the work contract. The available number of places for psychotherapy was far too small, and the supply was particularly poor when specific language skills were required. Hospital and day hospital care couldn't be offered as a substitute for psychotherapy. Within the health system, this is not their job, and hospitalization days need to be justified to the insurance system. For Ms. Massad, this particular mix of practices meant that she would be released from hospital with no adequate options to help her get better. In this situation, the concept of chronicity was used to highlight regular adverse effects of the welfare system. Remember that the doctor spoke of a classic example of chronification. This reference to chronicity raises very important questions about the causes of chronic illness and their temporalities. At the same time, we learn that perfect hospital accountability can bring deterioration in patient health. The concept of chronification allowed to shift the responsibility for the patient's recovery away from the hospital. In my last example, I want to turn to a very different setting, which is community care. In Berlin, community services were created in the 1990s to implement the deinstitutionalization of psychiatric treatment that society had been calling for since the 1960s and 70s. People who lived large parts of their lives in psychiatric treatment in large remote asylums finally got the offer to move back to the districts of the city and use psychiatric facilities as clients. As former asylum patients, this group of people was commonly referred to as the chronically ill, and the accepted view was that the miserable conditions in the asylums caused their poor health. Community care should provide them with fundamentally different living conditions and promote their health. In 2013, I did research in 4 community facilities that offered accommodation, leisure activities, daycare, and sheltered workshops. Unlike in the day hospital, all clients here were considered to be chronically ill. The act of classifying an illness as chronic therefore could not do any work that helped sorting tasks, resources, or responsibilities, as it was the case in the day hospital. To the contrary, community care has become the new territory of the classification, even if dispersed. Everyday practices in these institutions directly determine what it means to be classified and treated as chronically mentally ill in our societies. In other words, we can learn how chronicity is defined in daily practice by attending to the ways in which these facilities care for their clients. The result of my analysis is that much of daily care revolves around the presence of clients. Presence is not a matter of course, but entails work. For the analysis of this type of work, I have established the analytic of doing presence. I coined this term to make it clear that presence cannot be taken for granted, but must be established anew from day to day. Hence, the term embraces all the work that goes into making a client present in the services. This work involves the clients themselves, professional helpers, bodies and forms, software, furniture, and medication, to name a few. Presence is coordinated, permitted, or denied, calculated, practiced, shown, and achieved. Doing presence is a core practice that occupies daily life of people who participate in community services. If we study the details of this practice, we can therefore improve our understanding of how chronicity is not just embodied in biographies and bodies, but also in institutions. Let's have a closer look how clients accomplished the task of being present in a psychiatric daycare center. I have again an ethnographic note which I will read out loud. After a meeting with the professionals in the morning, I take a seat in the hallway. About 7 clients are seated there on individual chairs. Nobody talks to each other. Some professionals turn up and inform some of the people about the groups they will be part of this morning. Professionals and clients are on familiar terms with each other. Some of them joke. There is silence interspersed with client-professional interactions for several minutes. Apparently a routine, some get up 10 minutes before the groups start. They start talking to each other, head for the exit, and I understand that they are going out for a smoke. I join them in the courtyard. There, some of them engage in chats and include me in the conversation. End of the sequence. This ethnographic sequence gives an example of what practicing presence is about. Practicing presence is very much about learning when and where to be present and how. Clients seated in the hallway at a particular time in the morning did so because they knew that this was the moment when they could easily catch staff or staff could reach out to them. Smoking was allowed, but in the courtyard only. Rarely did staff members smoke at the same place. To several clients, presence was a challenge out of many reasons, one of which was co-presence with other clients in groups. Sometimes being present was a burdensome task. Please join me in reading the next ethnographic note on Ms. Bauer's presence in one of the therapeutic groups. During a memory training group, Ms. Bauer is apathetically seated on a chair. She does not involve herself in exercising. The leader of the group ignores her. Later, he asks Ms. Bauer whether she would like to rest in the relaxation room. She agrees, and he tells her that he will wake her up after the general break. End of sequence. Ms. Bauer was present and attended the group program. The group leader deemed her presence inappropriate for the group and directed her to the relaxation room. Later, I learned that she was taking high dosages of a tranquilizer, which made her very sleepy. The leader of the group told me that he was very sorry that no one in the daycare center knew her without medication. Medication, its effects and side effects greatly influence the possibilities to be present in community care facilities. Medication enabled certain forms of presences and hindered others. In Ms. Bauer's case, the effects of her medication enabled her to visit the daycare center in the first place, but impeded active involvement in group activities. Against the alternative of absence, tiredness became the standard way of being present in community care in her case. Ms. Bauer's case is only one example with which I wanted to make you aware of the details of everyday life in community care. My general argument is that it is of utmost importance to understand how practices of doing presence regularly shape the possibilities of getting a client position for those among us who have been classified as chronically mentally ill. Not least, community care facilities have taken on the legal mandate to enable people with chronic mental illness to participate in society. Everyday practices in community care and the concept of chronicity therefore mutually constitute each other. Chronicity is not an abstract, easily delimited concept. By the way, this is true for many concepts. On the contrary, the concept is integrated into everyday institutional life in a wide variety of ways and gains meaning in everyday institutional events. I'm coming to my summary. In the day hospital, as demonstrated, the concept of chronicity obtains meaning through everyday classification practices that help professionals to sort decisions of care on a daily basis. Here, single situated acts of classifying become consequential insofar as they establish connections between people and the welfare system across various sites. At the same time, the analysis has shown that chronicity is used as a concept to highlight the tensions and shortcomings of the current German welfare system and to find a way of dealing with the limits of hospital care in practice. For the analysis of chronicity in community care, I have introduced the analytic of doing presence for getting hold of one central daily process, which is the work that goes into making clients present in the services. As community care facilities have been historically established for people who are living with chronic mental illnesses, everyday practices of doing presence in these facilities determine the current meanings of the classification. If we want to know more about the effects of chronicity, it is therefore important to go and observe the practices that constitute institutional life. Finally, I would like to invite you to rethink chronicity in terms of practices. My argument is that turning chronicity into an empirical artifact enriches our understanding of the concept and the multiplicity of meanings it acquires in our health institutions. Chronicity cannot be solely considered a characteristic of an illness or an experience of an individual person. Rather, we can gain from studying it as a conceptual tool, an artifact that is involved in shaping the arrangements of care and welfare in daily practices. I have arrived at my final slides and would like to acknowledge all my colleagues at the Laboratory Anthropology of Environment Human Relations and also my former colleague, Martina Klausner, who is in the audience today. With her and with Jörg Niewöhner, I was enrolled in the ethnographic research project, the production of chronicity in mental health care and research in Berlin, which was funded by the German Research Foundation. So you can find my publication list and also the reference for the paper I've mentioned at my public ORCID account. And for follow-ups, please directly contact me at my email address. Thank you very much for your attention.
Thank you so much, Milena. This was so fascinating. Would you mind unsharing your screen so we can see you for the Q&A? Wonderful, thank you. Yes, let me do that in person. So the floor is open for questions if anyone wants to jump in. We don't have questions in the chat at the moment, so please feel free to just raise your hand, unmute yourself, and ask your question. Emma.
Hi. Thank you very much. Very interesting talk. And something that I was wondering as I was watching it was whether you have done a similar type of work, but with the physical care system, and whether you think that chronicity you'd have a similar sort of conceptualization, thinking about how physical care is conceptualized.
Thanks. Yes, that's a very intriguing question. I regret that I haven't done comparable ethnographic research on in different health domains. So I suppose that chronicity in mental health has very particular specificities. In the beginning of my talk, I've just very briefly pointed to the importance of chronicity also for the development of psychiatry as a medical specialty, and how care has been organized. So there was principally a split in taking care of chronically ill people in the large asylums, as we know, and like having and developing psychiatric treatment techniques in hospital settings. So there was this split already in what kind of therapeutic methods were applied to people whose illnesses have been classified as chronic or curable. So I think that's maybe particular to the mental health domain, but of course also the recovery movement and earlier the deinstitutionalization movement have contested the classification very strongly, and nowadays there are many other classifications that that replace several of the aspects that chronicity carries in its package, with it, which, for example, like the revolving door principle, so that people come back to treatment and remain in the care system. So some other terms have replaced but parts of the meanings of chronicity in mental health, and I would myself like to know more about chronicity in other physical health domains, if we want to stick to these root separations of the body and the mind and physical and mental health.
Absolutely, and I think particularly with the emergence of more long-term conditions, yeah, it'd be quite an interesting project to do as well, I think. Thank you.
I agree. I see one hand by Claudia. Can you see it, Dorte? But I just invite you.
Yes, I did. I'm sorry, I was muted. I actually called on Claudia and then realized I was muted. Yes, Claudia, please go ahead.
Okay, thank you. Thank you, Milena, for this really inspiring and interesting talk. I wanted to ask you whether in your analysis you saw the concept of chronicity being embedded in a broader, like, structural thinking of temporalities, or what other forms of temporalities might kind of come together with it in practice. And yeah, if you notice this, if this is something that's interesting for you in your analysis. You mentioned that it's used to point beyond the temporality of the hospital. But what I'm asking is, I think, more other temporalities in the hospital that or notions of temporality that the concept of, or that this concept is kind of tied to, or yeah, what's relations maybe there? Yeah, that would be interesting, because I mean, there's timing. You could think of different temporalities or concepts in temporalities that could matter and could be kind of intertwined with specific notions of chronicity.
Mm-hmm. Yeah, that's really a good question for further research as well. I'm not sure how far I can answer the question from my ethnographic work, because I haven't analyzed the multiplicities of temporalities that interact, but it makes immediately sense to me if I listen to your question. Yeah, it's hard. Like, as you said, there are temporalities beyond the clinic that are really frequently addressed when chronicity is invoked, and it needs to be explored further how beyond these temporal plannings and these references to time, how chronicity, or the concept of chronicity, entails several practices of timing and crosses with different concepts. I totally agree, but I'm sorry I cannot give a fuller answer to your question at the moment.
I'm sure you could write another paper about these aspects if you dig into your materials after 5 years of doing or 3 years of doing this ethnographic work. I'm sure you have a lot of material there.
You made me interested in looking back to it again. Thanks.
Thank you.
Do we have any more questions? That I would jump in myself with a question for you, Milena, because it's really, really interesting to see how you describe how the idea of chronicity shapes our institutions and the responsibilities for care and the temporality of care, and how your first two examples show how it is actually a mechanism to point away from institutions of care, or to sort of point towards the family, or towards a different horizon of someone else is in charge of it, the process from here. Whereas your third vignette and example really shows the place these other two places point to in the end. That's the institution that was created to hold, contain, to care for those then classified as chronically ill. In your research, have you talked to people about how they relate themselves to the label or the classification of chronic illness? And while your examples show how it is almost a shifting away from resources the moment chronicity is invoked, are there also mechanisms of the welfare state, for example, connected to gaining access to resources by being labeled chronically ill and so on? Because these concepts and terms, they're embedded in so many different societal mechanisms. So basically my question is twofold. On the one hand, have you talked to service users and how they feel about, or how they use and mention chronic illness, or the fact that their condition or the way they're being treated is classified as chronic? Yeah, basically to get, and also then does chronicity then also has an enabling aspect in terms of gaining access to a particular kind of resource? I mean, in a way it gains access to the third place that you showed us. But yeah, if you could speak to that a little bit, that would be really, really interesting.
Absolutely, yes. It's also crucial to say that chronicity, or like the classification of chronic illness, enabled or opened the doors exactly for people to enter therapeutic offers in community care. So there is like the classification is related to the resources that society has how do you say, like that society has meant to apply to the reintegration and therapy in cases of chronic mental illness. So it's an absolute resource as well in the German healthcare system. I spoke to a number of service users, how they understand chronicity, what it means to them, and in many cases it was about doubting or like also being worried about whether professionals classify one's troubles already as chronic. So there was a tail or like a trajectory. No, it was like more a tale of chronicity is something that cannot be cured. If my illness reaches this state, it will be hard to get any help. So this was a clear a clear thing people worried about as well. And also some of the service users told me of experiences when they contested being classified as chronically ill, or they shared stories how sharp some therapists decided that there was no help for their situation, like which is something which I also pointed at in my presentation, that chronicity also is somehow a possibility in certain situations to shift responsibility away of the healthcare system and to point to other players. And I think that this is what occupied a number of patients I had the chance to speak to.
Thank you so much. I see Hannah's hand is up.
Thank you, Milena.
Hi.
Really fascinating presentation and research, and I'm personally really interested in the idea of practice and what practice means, how we do things in this world and in mental health. And your concept of doing presence is I found that really interesting. And you said it's about making a client present in the services through different practices, but also material resources, realities, administration, I suppose. You listed a few. And sort of picking now or linking to Dorte's focus on clients, patients themselves, I was wondering what doing presence meant for them. I suppose it's not just about making others present, but also for people to make themselves present in the services. And what kind of tensions you saw emerging as people made themselves present in very different ways, and whether the sort of professional practices could be or were at odds with those of the clients. How were these kind of tensions or ruptures resolved or not resolved in the process of this sort of intertwining tensions that evolve as people make themselves present in different ways, and possibly, or I suppose often also in conflicting ways. If you could talk a bit to that, that would be really interesting.
Thank you very much. Indeed, tensions. I think the tensions are the cause why probably doing presence is such a central practice in community care. I chose Miss Bauer's example because there is already tension there. It's not fully elaborated, and it's not it has been solved in this situation. But if we look closer to the moment, then the solution is just to relocate Miss Bauer to a room where she will have no like care provision or like no company or whatsoever, and we don't know, and I don't know because I couldn't follow up with Frau Bauer, which I'm very sorry, how what if that's fine for her or if it's not fine for her to spend hours in a relaxation room, because as I have said, nobody knew her without her medication, and she was really extremely tired, and so tiredness was I considered of being part of the way she is a person there in community care. So the question is, how can situations like this one be solved, and how are they carried further? And there are other conflicting situations, because every client has a personal agreement with staff members, and in these agreements there are always topics that point at these moments and practices where tensions arise. So like being in time, of course, all these institutional rules, but then also people, I remember one client who was super compliant with everything, and who enjoyed a lot being in the groups and so on. How then when he wanted to move from his current flat into a shared flat with friends, all sorts of complications arose, and frictions came up, and then new tensions also entered into his like a known space in community care. So what I want to avoid is that that being present is an individual project. It involves care users, but of course it's something that is achieved in a particular setting together with other people and also surroundings. So I hope that this is in part answering a bit your question.
Yeah, thank you.
Great, thank you so much. Do we have more questions? If not, I have another one in the meantime while people are gathering their thoughts. You said in the beginning that concept work is a way for social scientists to intervene on the world, and that this is a way in which we can make an important contribution. Can you elaborate on that a little bit, and on the way in which exploring basically the institutional embodiment of a concept like chronicity can perhaps point to other futures or to other possibilities, or what kind of intervention can be made on the world by honing in on concepts like that?
Mm-hmm. Yes, I mean, you know, in the social sciences, much is about showing how things could be otherwise. And I think that concept work, for example, the approach I have presented today, treating concepts as practices and seeing how they are involved in routine action, that this possibly shifts the focus of how we want to change concepts, or how we want to intervene into society, into societal questions, or situations of conflict as well. I think that concept work also is a possibility to work collaboratively with other people, experts in their field, to see how the mutual exploration of a concept changes the practices that go and come with the concept. So I think that that our world is full of things and stuff and people and organisms and concepts and ideas, and that concepts are one angle, one entry point into shaping our worlds.
Great, thank you. No, it's really, really interesting. It's almost like a meeting ground where one can collaboratively work on like you say, sort of an otherwise or a different possibility. Thank you so much. Do we have more questions? Do have time for maybe one or two more.
I myself would be interested to know how such an approach based on practice, theory, like challenges your thinking of chronicity. So maybe we could also use the time left to share a bit of your impressions.
Does anyone want to jump in? Well, let me just say from my perspective, I do appreciate bringing concepts and practice together in the way you do. It's just a very, there's often sometimes such a strong focus on discourse, on what people say or what you can find in print or in policy analysis of the way in which concepts are used discursively, and to really follow them into the world and to see the work that concepts are doing in practice, like you show, I think is really, really important. It might actually produce a much more complex and different representation of it. It's just a different idea of concept work to really put it back into life, affect, embodiment, enactment, and to really illuminate all these facets of concepts rather than just in discourse or in print on paper. So it does open up also very, very interesting research sites. I think what's really fascinating about your work also is that it's not so much only about the times when people have mentioned the word chronic or chronicity to you, but really to look at how institutions actually embody a certain concept and to sort of take them as a material manifestation of an idea, and to study what's going on within that institution, within that place that is based on this idea. So I find it enormously helpful to get away from an idea of knowledge that only exists in discourse and spoken and written words, but actually really look at the real world consequences of concepts. So yeah, thank you so much for that. Would anyone else like to join in, or Milena?
I just wanted to thank you for this brilliant summary. Thanks.
No, thank you so much. We have 3 minutes left, but it's also the afternoon, and I'm happy to wrap things up here unless anyone has final comments or questions. And Milena can maybe post her contact again in the chat if people have more questions and want to get in touch afterwards. And yeah, please join me in thanking Milena for this wonderful presentation. Fantastic work. And I look forward to collaborating in the future and learning from you, frankly. So thank you very much. And you find the links to all of our both center email addresses and Twitter accounts and so on in the chat. And I'll see you next time, hopefully. Thank you very much.
Thank you very much as well. Bye.
Bye.
Bye. Thank you.